everybody, and welcome. Thank you for joining us for today's call. This is Stephanie Hall with the NCC, and I'll be your host for today. This is the ESRD Learning and Action Network series focusing on bloodstream infection quality improvement activity. Thank you so much for all taking time out of your busy day to be here. Just a few reminders before we do get started with the presentation. We are streaming the audio over the computer speakers to free up phone lines in your facility. If you need to dial in from your phone, send us a message via the chat window and we can assist you. Echoes, if you're hearing any echoes are usually caused by multiple connections to a single event, so please close all but one browser. And submitting questions and comments, currently we have everybody on mute on our end, but we do want to hear from you, so please type any questions or comments in the chat with presenter section located in the bottom left-hand corner of your screen. The event is being recorded today, and all the material will be made available from your network representative within 10 business days. So what's the reason for attending this LAN today? We're going to learn practices from dialysis facility staff who have low incidence of access-related bloodstream infections. And ways to spread these best practices from today's LAN. Going to listen and share your approaches and experiences via the chat. You're going to be able to identify how this shared information could be used at your facility. And we ask that you apply at least one idea from today's LAN, something that you can take back that you can implement at your facility within the next couple weeks. What can we commit to do today? We want you to identify and implement one action item from this meeting, something that you can that can be used directly to decrease the number of BSIs in your facility. Before we get started, I do want to just share with you, many of you took the time to fill out the pre-work questions that we set out. So there was two of them. The first one was, does the facility where you work educate patients on signs and symptoms of sepsis? 432 respondents, and overwhelmingly, 92% yes, they do. They do educate their patients on signs and symptoms of sepsis. The second question was, does the facility where you work use the ESRD network resources to educate patients regarding access choice and bloodstream infections? Again, we had, out of 433 respondents, 83% yes, they do use the ESRD resources, and 17% said no, they do not. So thank you for everybody who did take time to answer those questions before the call. And again, just a reminder, this event is approved for one CEU. At the end of the presentation, a post-it survey will appear, giving you the opportunity to share your feedback. After hitting the submit button, another screen will appear with the link to the CEUs. So please, we do ask for your feedback, and even if you don't need the CEUs, we still like to hear from you, and we do appreciate any feedback that you do give us. So with that said, I'm going to go ahead and we have sort of a panel today. There'll be 4 speakers. I'm going to go ahead and introduce all of them. The first one is Barry Rubin. He is a registered nurse with 40 years experience in critical care, medical, surgical, and in dialysis. Currently, he's the facility manager of a 60-patient home dialysis unit serving East Phoenix and Eastern Arizona, and the clinical practice administrator dialysis for Maricopa Integrated Health Systems, responsible for 2 outpatient dialysis units and inpatient dialysis units. Marek Patyniak is a clinical resource leader for Maricopa Integrated Health Systems. He also has been a dialysis nurse since 1991 and worked as a staff nurse in chronic and acute dialysis units for 14 years. Jinkee Borja is a clinical resource leader for the inpatient acute dialysis facility at Maricopa. Ms. Borja is a certified nephrology nurse and has a total of 21 years of experience as a registered nurse, with 12 of those years in dialysis. Lastly is Helen Rosales. She is a clinical resource leader for the Maricopa Integrated Health System in Glendale, Arizona. Ms. Rosales has worked as a registered nurse from Maricopa in Glendale since 2009 and is a certified nephrology nurse with over 13 years of dialysis experience. Today, they are going to talk about their dialysis facility and how they have managed and decreased the access infections. I'm going to turn it over to Barry.
Thank you, Stephanie. Next slide, please. The objectives of this information presents access infection rates at Maricopa Integrated Health System Dialysis Unit, and we've taken that data from the NHSN historical perspective to illustrate the supplies, tools implemented to help lower our infection rate here at MIHS, describe innovative staff practices to help reducing the BSI rate at MIHS, and the outlined concerned education for infection prevention in the renal patient population. Maricopa Integrated Health System, soon to be Valley Wise Health, is a not-for-profit hospital system governed by the Maricopa County Special Healthcare District located in Phoenix, Arizona. The dialysis program here consists of an inpatient unit, a unit at the Comprehensive Health Center on the main campus, which consists currently of 60 patients, and the Glendale Family Health Care Dialysis Unit in Glendale, Arizona, consisting of 42 patients. I'm now going to give you an overview of our access bloodstream infection with data from the NHSN for the CHC and the Glendale units from January 2012 through today, September 3rd, 2019. Next slide, please. As you can see, the access infection rate at the CHC has decreased significantly. From January 2012 to November 2016, we had 7 access infections, including 5 catheter and 2 fistula graft infections. From November of 2016 till September of 2018, we had a total of 735 days without an access infection. A year ago, September, we've had our first access infection, so we are now back to 365 days without an infection. At the Glendale unit between next slide. Next slide, please. There we go. At the Glendale unit between January 2012 and April of 2017, there were a total of 13 infections, including 7 catheter and 6 fistula. Since the last infection at Glendale on April 29, 2017, the unit has gone 856 days without an access infection. Besides our intense focus on infection control, we attribute our low access infection rate to our aggressive goal of replacing dialysis catheters with permanent fistulas or grafts. Currently, only 3% of our patients have catheters. The Glendale unit currently has 3 patients with catheters, and all of those patients have had permanent accesses placed. So in the next few weeks, we hope to have 0 catheters at our Glendale unit. 85% of our payer source is Federal Emergency System, FES, meaning that these patients cannot get a fistula or graft prior to the initiation of chronic dialysis. All or most all of these patients have come to us with catheters in place. Now, Marek will review the tools and supplies we use for access dressings at MIHS.
Hello everyone, this is Marek, and as you have seen from previous slides, in the past we have not served our patient population at a level that was satisfactory and, quite frankly, acceptable to us. In the years of 2012-2014, we have had an average of more than 2 access bloodstream infections between both units in 1 year. Our catheter rates, although acceptable by CMS standards, were greater than what we would like. Before we go to the next slide, I would like to give you a little overview of what has changed since then in both of our units. In addition to updating our policies for staff and patient education, which will be discussed in detail at a later part of this presentation, the management with the support, and I have to emphasize the support of our organization and leadership, has implemented some simple yet very effective improvements to our approach to patient care. A single person has been dedicated to overseeing fistula placements. In both units, it is the unit's manager's responsibility to do so. This has resulted in most patients getting their vein mapping done within 2 weeks of admission. We believe that removing catheters as soon as possible is one of the most single effective procedures to avoid access site bloodstream infection. Side note, due to Medicare regulations, most of our patients are not eligible for fistula placement prior to initiation of treatment. Otherwise, we would strive to do vein mapping and fistula placement prior to admission. The next slide, please. With the help of our leadership, we were able to meet with medical equipment vendors in order to put together evidence-based appropriate catheter dressing change kit. It was simple yet powerful step to streamline and standardize the catheter dressing changing procedure. The next slide, please. As we know, the catheter dressing change is an aseptic procedure, but it was decided to use a sterile dressing change kit in order to provide an extra level of protection. What is in the kit? Face mask for both patients and staff, sterile gloves, antibiotic disc, ChloraPrep for access site disinfection, sterile barrier, clear occlusive dressing, gauze, skin cleansing swab to remove any remnants of adhesive from previous dressing, alcohol pads, and measuring tape. The catheter dressing is changed every 7 days in compliance with the manufacturer recommendation, but of course, we'll change it more often if needed. The next slide, please. In addition, a Tego connector and a Curious cap were introduced. The Tego connector is also changed every 7 days, as recommended by the manufacturer, which limits patient exposure to the elements and coincides nicely with the dressing change schedule. Curious caps provide additional protection for the patient while between treatments. Of course, the Curious caps are changed every treatment. The next slide, please. Sterile recirculation adapter. This is used when patient's blood needs to be recirculated for whatever the reason may be, bathroom breaks, cannulation problems, etc. This adapter is used to maintain the sterility of patient lines, maintaining patient safety in the process. In addition, pre-filled sterile normal saline syringes are used for flushing the catheter lines prior and after the treatment, and when needed, of course. One additional side note, our staff changes PPE, including gowns, whenever there is a chance of body fluid exposure, which means between every patient's put on and take off procedure. It is our policy. All the tools presented above have been incorporated into our policies with ongoing staff and patient education. In our opinion, the leadership's vision of standardization and streamlining the catheter dressing procedure, combined with the staff education and patient compliance, has proved to be very successful in preventing access site bloodstream infections in our unit. I will now yield the presentation to Jinkee, who will present our staff education topics. Thank you.
Hello, good afternoon, everyone. My name is Jinkee, and I will be discussing staff education specific for our organization. So CDC has presented infection prevention tools that our organization utilizes that include core interventions, scrub the hub protocol, audit tools and checklists, and clinician education. Our organization that includes our dialysis interdisciplinary team has helped reinforce and sustain to understand and follow proper infection control procedures. We have utilized core interventions in reducing, if not prevent, dialysis access-related infections in our dialysis unit that comprise our comprehensive health center dialysis unit, which is in Phoenix. This unit has a census of 59 patients, 3 shifts a day, and our dialysis Glendale unit that's soon to be expanded and relocated in Peoria that is comprised of 38 patients, also 3 shifts daily. We have conducted monthly surveillance for access-related infection using CDC's National Healthcare Network reporting. Throughout the month, we incorporated audits that include RMDs, RNs, PCTs, social worker, renal dietitians, and other ancillary staff. Hand hygiene observations are done regularly along with opportunities monthly and results shared among staff in our huddles, our QAPI, and then monthly. Part of a pre-assessment flow sheet includes an assessment row to check if patient washed their access. Catheter, vascular access care observations are also performed all throughout the month. Catheter dressing change are performed by the nurse only, and this is through our policy and procedure. Dressing change weekly is done every Monday or Tuesday or as needed, and we also do competency evaluation that are done upon hire and annually. Staff education topics all throughout the year includes infection control topics and access care and aseptic technique. Our supplies for cannulation include needles, chucks, syringes, 3 alcohol pads on each site or more if needed, Band-Aid to cover exit site for AVF or AVG, and reinforced single-use tapes. For decannulation, we have no clamps to hold sites, as all our patients are encouraged to hold sites post-treatment. Patient engagement and education and infection prevention topics are spread all throughout the year with lobby day activities and hand hygiene implemented. Catheter reduction has been supported by our efforts of prompt referral for vein mapping on the first 2 weeks of starting in the unit. Primary nursing has also helped in reinforcing education for new starts. Our PCT access champion and a good working relationship with our vascular access coordinator are also important key efforts. Chlorhexidine for skin antisepsis is present in our catheter dressing kit. I know CDC recommends alcohol-based chlorhexidine of greater than 0.5% solution as our first-line skin antiseptic agent, and I believe our dressing kit has a 3 ml ChloraPrep of 2% solution. Catheter hub disinfection is utilized through the Scrub the Hub protocol. We also use a needleless connector device called Tegos that we have started using way back in July 2011. Tegos are changed weekly, and usually it's every Monday or Tuesday, and disinfected per manufacturer's instructions. The advantage of a closed system requires less manipulation with disinfecting Kuros caps for Tego hemodialysis connectors that will act as a cover between line accesses. This device effectiveness was tested in vitro against Staph aureus, E. coli, Pseudomonas aeruginosa, Candida albicans, and was found to have greater than 4 log reduction. And this is according to the manufacturer label. The cap will disinfect the needles connector 1 minute after application up to 7 days if not removed. And we do not use tapes to secure caps at all. Next slide, please. Clinician education.
Jinkee, we're going to do a polling question right now. So I will open this up. What is the most valuable education for staff?
So the most valuable education first. Okay. All right, good.
Oh, that's the polling question. Just sit tight. We're just
sorry, staff. I was just too excited.
Nope, just going to take a couple seconds to let the audience respond, and they're coming in. We've got over almost 400, so we'll just give them another second or two, and I'll close the polling in 3, 2, and 1. So let me share those. Those should come up on your screen. What is the most valuable education for staff? 26.3 said scrub the hub. Audits at 34%. Competencies, 28.4. And 11.4% said CDC education during orientation. So now, Jinkee, I'll turn it back over to you, and I'll advance it to the next slide.
All right. Thank you. For the clinician education, we do have staff competencies upon hire and annually that reinforces our policies and procedures on access care, and competency evaluation for our skills that includes gloving, hand hygiene, catheter dressing change, vascular access technique, safe injection, safe medication practices that include barcode medication administration technology. So we do have day since infection posters that are posted in our lobby boards that reflect our number of days of no access infection. So the education tools include infection prevention in dialysis setting training course that is accessed through our intranet staff education that was created by CDC in 2016 that comprises a 1-hour self-guided training slide presentation and audio narration. So these are examples of our current practice audit tools and checklists that we utilize from CDC. And we do have hand hygiene observations. We do have fistula graft cannulation observations. We do have catheter exit care observations, the connection and disconnection observations. And let me emphasize a little bit about hemodialysis station routine disinfection observations. Our hemodialysis station routine disinfection are most often performed by our RNs and PCTs working as a body system assigned in a pod. We do not use bleach. Instead, our organization has utilized the use of a specific surface disinfectant or decontaminant cleaner that we use on each station. And usually this has a contact time of about 2 to 3 minutes and are available in non-refillable containers. We also use a germicidal disposable wipes to clean other external surfaces and usually disinfects in 1 minute. Has a property of bactericidal, tuberculocidal, fungicidal, and virucidal in 1 minute. Our organization, on that next slide please, includes hemodialysis injectable medication preparation audit tool. And we have utilized single-use vials for heparin doses and pre-filled medication for our ESA doses. Next slide, please. Hemodialysis injectable medication administration is part of our audit tool, and this is very helpful since our organization uses barcode medication administration systems that includes electronic scanning systems in conjunction with our electronic administration records. So this is our EMR systems that captures medication administration in a timely manner and intercepts medication errors at point of administration. So I hereby present to you Ms. Helen for the patient education presentation. Thank you very much.
Good afternoon, everyone. My name is Helen Rosales, and I will be discussing about the different patient education and engagement activities that we have been adopted and implemented in our dialysis units. This core intervention, along with the staff education, the tools and supplies that we are using in our units, are essential in preventing and reducing our vascular access-related infection rates. Monthly patient education is critical in our campaign against infection. Every month, we provide our patients with infection prevention information. The topic for each month focuses on a specific area, such as vascular access care, hand hygiene, risks related to central venous catheter use, recognition of signs and symptoms of infection, and vascular access management, especially when the patient is away from the dialysis unit. These educational materials can be in a form of a handout, brochure, flyer, poster, or in a video presentation. Our Hispanic patients are provided with the Spanish version of the educational materials. Next slide, please.
And I think we have our polling question up here. Helen, so just take a moment here and opening it up to the audience to what is the most valuable education for patients? Access choice, hand hygiene, access care, or signs of infection. So we'll take a moment to let everybody have an opportunity to answer that. They're coming in fast and furious here. And I will close the polling out in 3, 2, and 1. And here are the results from the polling question. What is the most valuable education for patients? 10.7% said access choice. 57.9% said hand hygiene. 15.6% access care, and 15.8% said signs of infection. So very good. Helen?
Okay. Next slide, please. Can you do the other slide, please, before this, Stephanie? Lobby Day is a very excellent venue for providing patient education activity. Last year, we conducted a Lobby Day on infection prevention with emphasis in hand washing and hand hygiene. Next quarter, we are planning to hold a Lobby Day on vascular access care. And since 80% of our patients are Hispanics, we have an interpreter present during our Lobby Days to ensure that accurate information is being conveyed to our patients. Patient Infection Prevention Campaign Pledge. This quality improvement activity will help engage and empower our patients to take the right steps to prevent infection. The patient will take a pledge to protect themselves and others by performing infection prevention practices such as hand washing, washing of vascular access before dialysis, or by keeping their CVC site dry. Participate in hand washing observation, and most importantly, reporting to the healthcare for any signs and symptoms of infection. Next slide, please.
Helen, if you could just speak up a little louder.
Oh. Education and information materials such as flyers, posters, and signage on hand washing are displayed in the lobby, near the sinks, and in the treatment floor. This will serve as a reminder to our patients the importance of washing their fistula or graft, especially before and after treatment. Washing of fistulas and graft before each treatment are documented in the patient electronic medical record. This is one of the best practices that we have implemented to enforce compliance and sustainability. During the pre-dialysis assessment, the nurse or the PCT will assess and document if the patient performs the procedure. Lastly, we incorporate our efforts to reduce catheters through patient education. The newly admitted patients with CVC are referred to the vascular center for vein mapping and access placement within the first 2 weeks of admission. During that period, we focus our patient education in identifying and addressing barriers to permanent access placement. The next slide is about, this is called the Sepsis Zone Tool, prepared by the Health Services Advisor Group, Esrd Network 15. This tool can help the patient in identifying the presence of infection and or sepsis. Green zone means that there are no signs of infection. The yellow zone means patient may have an infection and that they need to contact their doctor or healthcare providers. Red zones means signs and symptoms of infection are present and that they need to act fast by calling 911 or by going to the emergency room. Next slide, please. This material is an excellent resource for the patient with CVC. It is a trifold brochure about caring for a central venous catheter and how to recognize and troubleshoot problems. This education material is also available in Spanish, and you can download this from the HSAG Network 15. Next slide, please. To wrap up our presentation, I am giving the floor back to Marek.
So as you can see, our success story has not been updated. So currently at the CHC, we are 320 days. And in Glendale, we are at 56 days without infection. And in conclusion, I would like to say that we presented to you what has worked for us. We have everybody on board and everybody buy in, including the doctors, the dietitians, the social worker, dietary. We understand that all units are different when it comes to the patient population, policies, and leadership abilities. What we have presented made a big difference in our patients, in our units. We hope that our presentation has provided all of you who need it with a guiding blueprint for what may work in your unit as well. We appreciate your attention. Thank you very much.
Thank you. Thanks everybody, the panel, for presenting a lot of good information and obviously very good results. Again, the Maricopa Integrated Health Systems decided just to focus on access BSIs. So just as a reminder to everybody, they are reporting today just on the accesses, how successful they've been. And I think before, there's some questions coming in through the chat, but I would like to ask the panel and I don't know who would speak to this, but I know Barry mentioned it and Marek, you mentioned it early on in your presentation about your low catheter rates. And to me, that's I'm very impressed and very interested in how successful you are. Can you speak just a little bit about how that works, what kind of system you have or process you have in place?
Yes, so we are lucky in Phoenix. We have a center, access center that cooperates with us very closely. The physician group that covers our unit is also part of that surgical center. So we have a dialysis technician champion for dialysis, for catheter removal, and I personally oversee the vein mapping scheduling for patients, and I have a designated person at that center who works closely with me on new patient fistula or vein mapping and fistula placement. So that's been a tremendous help in replacing the catheters with fistulas and grafts.
May I ask, is it you or do you have a person who does the sort of a vascular access leader, if you will?
So I am the leader, and so is Helen in Glendale. So we both we are the charge nurses, so we manage the units. We are the leaders in vascular access replacement or placement, but we both have champions from the technician point of view. So we also have, we do venous monitoring once a month. Those are the technicians, and they will come to us immediately if the Medtronic's monitoring that we do shows any problems with flows in a fistula or grafts. So it works really well for us. It's a teamwork, and like everything else, I think that teamwork is the key to success in every dialysis unit setup.
Thank you. Barry, anything you want to add to your low catheter rates?
Everything Marek said. I mean, we function as a group, as a team. Our nephrologists are fantastic. We have a fantastic medical director who supports us, and it shows, every month in QAPI we show our number of accesses, what types we have, our catheter percentage, and our infection rate. And, month after month, especially at Glendale over the last year and a half, or almost 2 years, 3 years, they have not had an access infection. And unfortunately, a year ago this month we had one here, but we started right back right back with us, like we fell off the horse, we're going to get back up, and here we go again. So we're at 365 days again. So fantastic group of dedicated nurses.
Thank you. Thanks for sharing that. There are some questions, so I think I'll jump in, and they're not really directed for anybody, so whoever feels like they want to speak, go ahead. The first one is more like a little comment. It says it's from Andrea, and she says, I would like some one-page education that I could hand out to patients. I want to implement more patient education and auditing. I can only find ones on the CDC website. Any recommendations for her?
One, I think the page or literature that you hand out to patients sometimes would not be very effective based on the organizational practice that we're using right now. I think one of the most impactful activities that we did very recently that really kind of, patients have good memories about it is our lobby day. So when we have lobby days, hand hygiene, infection control, hand washing activity, it was a very good educational tool that we found the most effective, that you can do your handouts, you can do your interaction from the staff, and you can do like return demonstrations and really checks, how they retained or how they handled getting that information that you imparted to them on that day.
Thank you. And I do want to give you a shout out and kudos for mentioning on your lobby days you have an interpreter. I think that's, and I know where you're at, your location is a high Hispanic, but still, I've not heard that, and so nice job on implementing that. Here's a question. It was mentioned that they do not use tape to secure the catheter caps. What do you use?
So to secure the I wanted to make sure that we are talking about tapes that secure the limbs of those catheters. So we don't use any tapes at all, and we just leave them there, but we use the Tegos and the Curos that caps those catheter limbs.
Thank you for clarifying that. Yolanda says, could I get the name of the disinfection wipes and substance used for station disinfection?
So we do use Cavicide. This is a specific manufacturer that we use for our organization. And I would like to commend that this is not just a dialysis effort that we are imparting, but we also use, we need the purple. It is an organizational-wide practice that's supported by leadership and the organization as well, that would provide us the resources to support us of, refraining or preventing or reducing infection in the unit. So we do have a Sanicloth bleach. This is from PDI, and we do have Cavicide spray that we use for our station disinfection. Perfect.
Can you can you spell that for everybody? Is it CL Cavicide?
So the Cavicide is CAVICIDE.
Okay, perfect. Good. Another question, if a patient is unable to wash their own access, does the staff assist? And if so, how is this done?
Hello, this is Helen. Yes, our staff are trained to assist our patient in washing their access. So the most important aspect of this one is that we make sure that there is plenty or ample of time in between patients. So the technician or the nurse can help the patient, especially those patients who are blind or who are in the wheelchair. So I think the key there is that we give more time in between patients.
Okay. Thank you, Helen. A question, what are the barriers you have identified to permitted access placement, and how have you overcome them?
So that the most obvious barrier that we have is patient insurance, and our social worker works closely with me and with the surgical center to resolve that issue. That is the biggest barrier that we have. There are some patients, of course, who are very reluctant to have the catheter replaced. We currently have 2 patients in our unit who do not have any other access other than the catheter simply because they refuse. So we continue on talking, we continue on encouraging. Like Barry mentioned, our medical staff, the doctors are outstanding. I can't speak enough of them. And so each time we make rounds, both the medical director and the other physician who covers the other shift emphasize the importance. But of course, there's only so much we can do. So I would say these are the 2 most prevalent barriers that we have to replacing the dialysis catheter with a fistula placement.
Thank you. Thanks, Marek. Let's see. Dialysis patients who have a AVF or an AVG and using EMLA cream to their access coming to the unit, do they wash their access prior to cannulation?
Yes, we do. So part of the education for our patients, even if they use EMLA cream, they still have to come into the unit, they weigh, and then they wash their hands with that cream still in there. They take off that plastic wrap or saline wrap that they're using, and then they still wash their hands before cannulation.
Good, thank you. What antibacterial do you use to scrub the hub?
So we do have alcohol pads that we use, and we have chlorhexidine preps that we use in the unit.
Good, thank you. Okay, we have another question from Patricia. Are the alcohol caps used instead of scrub the hub, or is scrub the hub needed if the alcohol caps have been on the line after the 1 minute as stated in your presentation?
All right. The 1 minute is the Kuros cap, so I don't want to confuse the listeners for this one. The Kuros that we use are the caps or the end caps that secures the Tegos as well. So that has a 1 minute minimum contact time. So that's different from scrub the hub. So when they do the scrub the hub, it has to be alcohol pads on each axis on those hubs.
Thank you for clarifying that, Jinkee. Melissa wants to know, is Network 15 site the only place you can get the CVC care pamphlet, or is it the same information on every network?
For that particular brochure, I think that is developed by the Network 15. Okay,
but I just want to tell everybody too. Anybody can certainly go in. Google Network 15's website, and you'll be able to have access to it. And so it is out there for anybody to use. It's just Network 15 happened to have developed it. If it's on their website, it's for anybody's use. So, but do check your own.
Yeah, that is correct. Network 15 has a website accessible to anybody, and if you go to patient education or staff education, you will find all kinds of resources. Very helpful. I would highly encourage everybody to go to Network 15 website and check it out.
Correct, and as well as your own networks, everybody they have a lot of information out there for you too, and resources. So a question: when do you remove the catheter sutures?
The catheter sutures are this is a doctor's order, so we normally don't remove them at all. The patient goes back to the surgical center to have them removed.
Okay. How have you dealt with patients on the first shift that say, my arm is clean, I just showered?
For our first shift, I think it's a common, regardless if it's first shift, second shift, third shift, we still have those patients that would tell us that. It's a continuous reinforcement, and part of it is, we have the visual, we kind of observe the patients when they walk in, wash their hands, and then we do have, I think I mentioned that on my presentation, that in our pre-assessment part on that row, there is a questionnaire, did the patient wash their access? So that's a reiteration of the observation part of it, and then we have to educate them that, yeah, you can go back to your chair. And since we're not in a no-rush zone where, we have the patients are in the station, they're about to take their blood pressure, and they would say, hey, I just showered, we just ask them politely if they can go back and wash their hands. This is part of our procedure in the unit.
Thank you, Jinkee. Do you allow PCTs to do dressing changes or just nurses?
No, the PCTs are not allowed to do any dressing changes, only the nursing staff, and it's also, this procedure is reinforced on an annual basis by our nurse educators. We have 2 nurse educators on the unit.
Good, thank you. Did you include BSIs with attribution of source unknown or only those with access as confirmed source? And that's when reporting to NHSN.
So we do report to NHSN all of our infections, but today's presentation was, we concentrated on just the access site infections.
Okay, let's see. We've got a few more questions, and we still have a few more minutes, so I think we're trying to get through here. And let's see. Did I understand you to say that your staff dons a new gown for catheter care?
That is correct. In addition, we change our gowns between every put on and every take off. So we go through quite a bit of gowns. Again, I need to emphasize the support we have from our organization, our leadership, that bought into our policies and supports us 100%. So yes, we changed the PPE between every takeoff, every put on, and before we do dressing changes.
Perfect, thank you. I think back to Jinkee, what you were saying, a question came in, how much time between patients? I think you mentioned you try to spread that time out and so they're not rushed. How much time do you have between your patients?
So we do have 30 to 45 to an hour in between because we determined that some patients would have a longer waiting time or holding time. So we spread it all in. So it's an individualized care. So we don't just do 30 minutes across the board. So we do have 30, we have 45, and an hour in between.
Perfect, thank you. A question, how often do you change your catheter dressings?
So our dressing changes, our catheter dressing changes are done every Monday and Tuesday. It's every week, and then as needed, or if we see that it's soiled, it's wet, it's dirty, then we change it.
We have a couple patients who started out with a catheter in place and continued working, and so we changed those dressings every time the patient was here.
Okay, great, thank you. How often do you do your lobby days?
So every quarter we do lobby days. We try to identify issues on the unit. We have a patient advocate that we talk to and take suggestions from. Our next lobby day is in September. We'll do emergency preparedness. And we try to do quarterly different disciplines. So dietary input, social work, nursing, and physicians.
Good. Okay, good. Let's see. Charlotte asks, do you use the antimicrobial ointment on your CVC insertion sites?
We do have antimicrobial disc, and this is the BioPatch.
Use the BioPatch. Perfect. Okay, great. A couple more. Let's see. How's our time? Okay, we have time maybe for 2 or 3 more. Do you or have you had patients who adamantly refused a permanent access placement? If you have, what have you done to address this?
So we do. We have currently a patient who has not had a fistula for 3 years. He's been with the catheter in his chest for 3 years now. There's not much we can do. Patient adamantly refuses. We absolutely will not force the patient to do so. So we resorted to just being very careful, and for 3 years, knock on wood, he has not had any infection in his catheter. There is another patient who ulcer-refuses, as I stated before, we have 2 patients who do not have other access sites other than the catheter. This patient is still thinking. She's with us. She's been with us for 6 months. She's still thinking continuously. We try to educate the patient, and like I mentioned before, our medical director is absolutely outstanding when it comes to patient education. So hopefully, between him and the nursing staff, we'll be able to achieve some success.
Good. Thank you. Carmen says, your presentation is only for vascular access infection. Do you have any other type of bloodstream infections?
We do. So we will notice, especially for diabetic foot infections, we had some pneumonias, stump infections, UTIs. So these are the ones that I'm sure most units will notice in their practice.
When we have our QAPI, we do report on not only the access infections, but the other infections, and that is reported to me, and our medical director will go through and he'll ask specifics about what the other infections were. And as Marek said, most of them have to do with our diabetic patients.
Good. Thank you. Gosh, let's see. What do we got? Okay, maybe try a couple of these quick ones. And can you just tell us again, Kitty, I'd like to know what was your patient census?
The CHC, our big unit, currently has 60 patients, and our unit at Glendale has, they have 38. They can take up to 42. I think in my presentation I put that 60 and 42 is what we can handle. We hopefully in the spring, or not hopefully, in the spring, we will be closing down the Glendale unit and opening a unit in the West Valley that will have 12 stations plus an isolation. So we are really looking forward to that.
Good. Okay, here's another question. If you change your dressings weekly, how can you identify the exit site condition?
So the access site condition can be identified during pre-assessment. So our nurses are doing pre-assessment on most of the patients. So we have one tech, one nurse on each pod. Just a little bit different arrangement from other dialysis centers where they have the techs on each pod. We do have a buddy system that I have mentioned that has a nurse and a tech that covers and helps put on patients, takes off, takes care of. The pre-assessment specifically is the nurse's part, and that's the time we do assessment on the catheter site.
Great, thank you.
Yes,
did you?
Helen, I believe Helen has some more.
Can I add something?
Yes.
And our catheter dressing is transparent, so we can see the access site condition as well.
Oh, perfect. Thank you, Helen, for that. And what do you use to disinfect the catheter site when the patient is allergic to chlorhexidine?
So far, we've been lucky with no reactions or anything with chlorhexidine. I have personally observed that patients react to chlorhexidine in the inpatient part when you don't dry them, when you don't have to if it's too wet and you put your biopatch in and your sterile dressing in. But so far, knock on wood, we have no reactions or anything, and it was a practice that really takes that process of taking time to do the dressing change.
Good. Okay. Good for you. Let's see. Do you teach or allow patients to change their own dressings at home if the dressing becomes wet or starts to fall off?
We don't have any tools or resources that we let them have, but so far our patients understood the essence of having us change their dressing, and they know that the techs don't even change their dressing, and it's only the nurses. So there are days, it's not very common, but I know at one point in time we do have a patient that would give us a call and say, my dressing got wet and, can I come over there and have my dressing changed or something like that? And we do accommodate that effort.
Okay, great. Thank you. Very helpful. What time? Let's just do one more, and then I think it's 3:55. We'll wrap up here. Let's see. So in our unit, we do not use the Tego caps. Our caps are changed every dialysis. Do you recommend the same scrub the hub procedure?
I would say yes. Our practice has proven that, our infection rates have really improved, like we don't have a lot of infection. And I think it's a constant reiteration every day, and it's not going to be perfect on most of the staff, but the audit tools are really great tools to follow through with them.
Right. And how many seconds do you scrub the hub? Huh?
Our scrub the hub is usually 30 seconds within time frame on every axis of that site.
Okay, perfect. Thank you. I think I'm going to sneak in one more. It says, for the infection observation handout, is it possible to get a copy of those presented today, or do we create our own? And I can just speak to that and say that all of this will be sent out to the network representative within 10 business days. So you will be getting a copy of this, which will, of course, include, I can make sure you get a link to that. Those are off the CDC website. You can also go ahead and anybody can go Google that and just put CDC audit tools and it should come up. Also, I would look at your network websites too. They should have all the links on there, but I can also make sure it gets included when we send this out to everybody here. And let's see. Oh, just one more. Let's see. We've got a lot of good questions and a lot of good dialogue. How do you handle nursing home patients?
We currently don't have any patients in a nursing home. We had one, about a year ago, I guess was our last one, and she had a fistula, so we really didn't have any problems with that.
The good communication is really key. So what we would do in that case, we always communicated with the nursing home if there was any issues. The staff was very open to any of our suggestions as far as the catheter care. A few years ago, I went to that nursing home to present to the nursing home staff what to do with dialysis patients' accesses. So that would be something to consider. I'm not sure whether that's a feasible option for most units, but that's what we've done.
Staff, I have to add one more on that one. I know I could recall I think around last year when we have that last patient, we utilized, I know everybody uses a communication tool to send out to the nursing homes, and we utilized SBAR. This is a situation background assessment recommendation tool, and we follow through in making sure that that communication has been received and documented so we can have a very good follow through that both parties receive the communication.
Jinkee, can you just say real quickly what SBAR is, because there might be some people who are not familiar with that?
SBAR is an acronym for Situation Background Assessment Recommendation.
Perfect, thank you. Well, all right. Well, again, it's just about 2 minutes before our closing, and I just want to thank Barry, Marek, Jinkee, and Helen again for a great presentation. A lot of good things. A lot of good questions came in today, which really shows that, people are interested. I'm hoping, what we are hoping our goal, of course, is today, and what this call means for everybody is just taking one idea from today's call, from everything you heard, something you can commit to implement in your facility. I think there were lots of good things that can be implemented easily and quickly, simply. Just as a reminder, please stay on the call to get your CEU link and finish your post-survey event. We really want to get your feedback. Yes, sir. Yes, sir.
I just wanted to say if anybody has questions or anything, we will be more than happy if they contact us. Can I give them our phone number?
You can.
602-344-1601. That's the main number to the dialysis unit, and we would be more than happy to, talk and ask answer questions to anybody who would like.
Thank you very much. And if we get, and they also know to email the NCC info mailbox. And if we get questions, I will be glad to, obviously forward those on over to you too. I appreciate that, Barry, your offer. That's very nice. So again, in closing, just if you have promising practices like you heard today, we want to hear from you. We hold these lands, as you know, every other month, and we would love to hear from you and hear what your best practices, what you're doing in your facility. And again, just follow us on social media for any updates, Facebook, YouTube, or Twitter. And again, I just want to thank everybody who participated today, took time out of their day, as well as our panel, to share with us and joined us today for this BSI land. And we hope we have another one in November, and we hope to see you all soon. And thank you, and have a good day.
Thank you.
This concludes today's call. Thank you for your participation. You may now disconnect.